Ruben, I'm going to turn to you. For our viewers, Ruben chairs the NCCN MPN Practice Guidelines Committee. And so I would like you to comment on what the NCCN recommends for initiation of cytoreductive therapy. When do you consider that in terms of that choice? And then follow up on that with the comments of, is it hydroxyurea or interferon? How do you use those?
Great, great. So first, to give a proper credit, so I did initiate that group as the initial panel, but now chaired by our friend and colleague Aaron Gerds. But very, very familiar with the NCCN guidelines. I think they're a key piece. Both Serge and I were kind of on that initial wave, helping to set these up, and they're real positive in that they really brought some, kind of evidence-based standards to our US-based treatment. Cytoreductive need for high-risk patients in PV is really aimed at both decreasing that difficult risk of thrombosis and bleeding, but also trying to improve the disease burden with symptoms. So the two options are really listed as initial therapy, already building on that base, assuming that people have already been on phlebotomy and aspirin. So that's really a base, control of hematocrit and aspirin. The cytoreduction really then to try to achieve a European leukemia net response, phlebotomy independence, control of the white cell count, control of the platelet count, resolution of splenomegaly if there, and control of symptoms. So with that, either hydroxyurea or long-acting interferons. Both are felt to be a clinician's choice between them and the patient. And there's increasing data. So there's randomized data from earlier studies showing that hydroxyurea is superior to phlebotomy alone. It's an older drug, but people are frequently comfortable using it. Deficiencies clearly can be difficulties with cytopenias, mouth ulcers, cutaneous malignancies, and sometimes other associated side effects. Interferons, there is even an update coming up at this year's EHA. Just saw in the late breaking abstracts regarding the rho-pegylated interferon given every 2 weeks. In the US, most commonly, the pegylated interferon alpha 2A has been the available construct, but again, trying to achieve a good control of the counts. Downsides with interferon, it can cause mood disorders or rarely autoimmune problems such as hypothyroidism or flu-like symptoms. So both have their pluses and minuses. Interferon being the preferred choice in women of childbearing age or individuals who are pregnant.